Femoral neck fractures. 1. Epidemiology. Femoral neck fractures are one of the most common fracture sites in elderly individuals, ages 70 to 80. 2. Anatomy. Neck shaft angle. At birth, 150 degrees to 160 degrees. In adults, 130 degrees plus or minus 5 degrees. Femoral anteversion. 10 degrees to 15 degrees, the deviation of the neck to anterior relevant to coronal axis of femoral shaft. Intracapsular part. Anterior surface. Extends to the intertrochanteric line. Posterior surface. Extends 1.5 centimeters proximal to the intertrochanteric crest. Calcar femoral. A vertically dense oriented plate located at the posteromedial portion of the proximal shaft under the lesser trochanter, fusing with the posterior aspect of the femoral neck. 3. Mechanism of injury. Elderly. Low-energy trauma, direct and indirect forces. Young. High-energy trauma. Stress fractures, common in athletes and military recruits. Pathological fractures, due to underlying bone disease. 4. Classification. Anatomic classification. Subcapital, transcervical, basicervical. Powell's classification, based on the fracture angle from the horizontal plane. Type 1. Less than 30 degrees. Type 2. 30 degrees to 70 degrees. Type 3. Greater than 70 degrees. Garden classification, based on the degree of valgus displacement. Stage 1. Incomplete, non-displaced. Stage 2. Complete, non-displaced. Stage 3. Complete, partial displacement. Stage 4. Complete, fully displaced. Clinical presentation. Groin pain, deformity, internal rotation, shortening due to intracapsular content of neck. 5. Imaging. X-ray, AP, cross-table lateral, and AP with internal rotation. CT. Detailed evaluation of the fracture. MRI. For occult fractures and avascular necrosis, AVN. MCQ. Bone scan. Positive after 2 to 3 days for stress fractures. 6. Treatment. Stress fractures. Tension-sided fractures. Risk of displacement at the superior neck. Compression-sided fractures. Risk of displacement at the inferior neck. In situ screw fixation. For asymptomatic stress fractures, with protected weight bearing, WB. Non-displaced fractures. Fixation methods. Cannulated lag screws. 3 screws placed 5 mm from the subchondral bone. Inverted triangle configuration. Inferior, posterior superior, anterior superior for stronger fixation. Dynamic hip screw, DHS, for basicervical fractures, with an additional anti-rotation screw to control rotation. Cephalomedullary nail, PFN, Racon nail for associated femoral shaft fractures. 7. Displaced fractures. Young, less than 60 years. Open reduction and internal fixation, ORIF, commonly with the anterior, Smith-Peterson, or anterolateral, Watson-Jones, approach. Closed reduction performed early, less than 12 hours, to reduce the risk of AVN, using hip flexion, traction, and external rotation followed by extension and internal rotation. Prosthetic replacement considered for those with non-union or pathological fractures. Elderly, greater than 70 years. Prosthetic replacement, bipolar hemiarthroplasty if actabulum non-arthritic or total hip replacement, THR. 8. Complications. Avascular necrosis, AVN. Incidence, 25 to 50%. Risk factors include delayed or inadequate reduction and fixation. Non-union. If there is no healing by 6 to 12 months. Incidence, 25%. Risk factors include varus malreduction, inadequate fixation, or comminuted fractures. Treatment options. Recent fractures, revision and cancellous bone grafting. Old fractures. Valgus intertrochanteric osteotomy to realign the fracture and reduce shear forces. Elderly patients, arthroplasty or DA. Implant failure. Implant failure may occur, requiring further interventions. Cutout. And 9. Indications for prosthetic replacement. Displaced femoral neck fractures in elderly, Garden 3, IV. Non-union, AVN, osteoarthritis, OA, or pathological fractures. For patients with limited mobility, cognitive issues, or poor life expectancy, a hip arthroplasty, HAP, hemiarthroplasty, or bipolar, unipolar prosthesis may be indicated depending on the patient's activity level.